So now I would like to warmly welcome Associate Professor of Philosophy, Andrew Schroeder. His research and teaching covers a range of topics, including ethics, political philosophy, bioethics, the philosophy of disability, and the philosophy of science. And today he's going to share his presentation, What the COVID Death Count Really Means. Professor Schroeder, I turn it over to you.
Thank you so much, Jenna. Let me go ahead and get a screen share set up. There we go. So that, I'm going to move this over here. Thanks everybody for coming. As Jenna mentioned, I'm an associate professor in CMC's philosophy department. A lot of my work involves looking at ethical and political dimensions of scientific research. And I've in particular spent a lot of time working with epidemiologists, including some of the people who are doing a lot of work on COVID. And so for that reason, I've done a lot of work over the past year connected to the epidemic. I gave a talk in this series, I think it was last June, but sometime close to a year ago, back when we were just kind of starting up on all this, looking at COVID projection models, trying to understand what those models were telling us, what they weren't telling us, how people were using them correctly and misusing them. So I'm back today to talk a little bit about COVID statistics, and in particular to talk about COVID mortality statistics, or the death count that probably a lot of us have been paying a lot of attention to over the past year. So the kind of background to this talk today, back in November, I published an article about COVID mortality statistics in a kind of a popular science magazine. And so if you're interested, you can see the URL down there at the bottom of the screen. I'll show it back at the end of the talk, and maybe we can put it in the chat if that makes it easier for people. And so what I'm going to do for the talk today is to spend about 25 or 30 minutes summarizing some of the things I talk about in that article. There's more in the article, so if you find the talk interesting, you might get some more useful stuff there. So I'll spend about a half an hour summarizing some key things from the article, and then I'll wrap things up with about 5 or 10 minutes of more general observations about scientific statistics, how they can or should be used in public discourse and policymaking, decision-making. Okay, so the COVID death count, as of yesterday, according to the CDC, 555,231 people in the United States have died from COVID-19. For a lot of us, this number has kind of served as a running tally of how bad things have gotten. The changes day to day have served as a kind of indicator for whether things are getting better or whether things are getting worse. So by itself, this is a really important statistic. This statistic also feeds into other statistics that a lot of us pay a lot of attention to and that are important for all sorts of public and policymaking purposes. So a lot of you probably saw that last week it was officially announced that in 2020, the third leading cause of death in the United States was COVID-19. You can see the top, I think that's the top 10 causes of death in the US in 2020. This was a really big deal. In a country like the US, where the health situation is pretty stable, you don't typically see very much movement year to year in our top causes of death. And so to see just any new cause break into the top 10 is pretty surprising. And especially to see a cause jump all the way up to number 3. And as you can see from the graph, it beat out number 4 by quite a large margin. So that's a pretty shocking result. Many of us also use COVID mortality rates, so the number of deaths, say, per 100,000 residents, to compare how the US is doing relative to how other countries are doing, to compare how different parts of the US are doing. How's California doing relative to Texas or New York or Oregon? And of course, those mortality rate statistics all come from these basic mortality statistics. So I think this death count, or these mortality statistics, are pretty important for a lot of different purposes. So how are they put together? How does the CDC arrive at a number like 555,231? Well, that number is based on information that either comes from death certificates, or when death certificates are unavailable, the information that we would expect to find on death certificates. So specifically, that number refers to the number of deaths where COVID was determined to be the underlying cause of death. And the underlying cause of death is defined as the disease or injury which initiated the train of morbid events leading directly to death. Essentially, what that means is that if you catch COVID and then there's some clear line from the infection to your death, then your death is going to be considered a COVID death. So if you catch COVID, the COVID leads to pneumonia, and then you die, your death is going to be considered a COVID death since COVID was the thing that caused the pneumonia. Okay, so that's basically how the statistic is calculated. But as you all know, the CDC numbers have received a lot of pushback. In particular, a lot of people throughout the pandemic have been claiming that the CDC is inflating the true number of COVID deaths. They're overcounting the number of people who have actually died due to COVID-19. So here's a tweet from then Representative, now Senator Roger Marshall, who's a doctor, claiming that the CDC statistics were confusing people who died with COVID with people who died from COVID. Probably we should only be counting people who died from COVID, and he's claiming that there's some confusion here. Here's another tweet that went viral for a while. Someone is claiming that of the supposed 100,000 people who to that point had died from COVID, you can put them into 4 categories, and only one of the 4 categories are people who truly had COVID as the cause of their death. And you get similar statements from Dr. Birx and President Trump, both arguing that the US or the CDC has a kind of unusually liberal standard for deciding what counts as a COVID death. Okay, so there's a lot of people who have pushed back and argued that the death count is inflated. What lies behind those arguments? Well, of course, there's a lot of different people who have a lot of different perspectives, but the main thread that runs through all 4 of the people that I've cited here and a lot of other people who have argued that the CDC is inflating statistics is this. As most of us, as all of us know, COVID, of course, can be a very serious illness for anyone, but most COVID deaths do involve people who are either very old or people who have serious pre-existing health conditions, or both. So let's take what is unfortunately a pretty normal case. We have a patient who maybe has advanced COPD, late-stage cancer. That patient contracts COVID and then dies. Okay. Now, in this situation, it's of course true that COVID was involved in their death, but you might wonder whether it's really fair to pick out COVID as the cause of their death. If we are going to pick out a cause of their death, wouldn't it make a lot more sense to pick out COPD or cancer in these cases? It may be true that COVID was the kind of straw that broke the camel's back in this situation, but most of the burden, the reason the person was in such bad health was because of the cancer or the COPD. And so the general point here is that the official statistics that the CDC compiles take no note of how precarious or fragile someone's health was to begin with. But you might think that that has to be relevant when we're thinking about what was really the cause of someone's death. Right? Imagine you have a whole lot of money and one thief comes along and steals 99% of it, and then a second thief comes along and steals 1% of it. Well, you're probably going to be a lot more upset at that first thief, even if, okay, technically it was the second thief who stole your last dollar. Similarly, you might think that if cancer takes you from good health to terrible health, and then, okay, COVID takes you from terrible health to death, it's still really cancer that bears primary responsibility for your situation, not COVID. So why not say that that death was primarily due to cancer, or COPD, as I've written on the slide? Okay, so that's the kind of argument that a lot of people have put forward to claim that the CDC count is overstating the number of COVID deaths, because it is counting all of these deaths among people who have underlying serious pre-existing conditions, and it's not taking into account what their health situation was like before they caught COVID. That said, although many people have argued that the CDC count overstates things, there's a second group who have been publicly arguing that it's exactly the reverse, that many more people have died from COVID than the CDC count would show. So here are some examples of that. In mid-August 2020, the official CDC death count stood at about 165,000. The New York Times published an article that reported that the true toll had already passed 200,000. So the true toll was 20 or 25% higher than what the CDC was reporting. An article in the Journal of the American Medical Association similarly argued that the official tally is a significant undercount. And a more recent article quantified that by suggesting that the true COVID death toll was 44% higher than what the CDC was claiming. So what's going on right here? What is leading people to argue that the CDC is significantly undercounting the number of COVID deaths? Well, what these people all point out is that in order to qualify as an official COVID death, you have to be infected by the virus. Remember that definition I gave you earlier? We look at people who are infected and then we ask whether there's some direct causal link from the infection to their death. So the official count only looks at people who died and who were infected by the virus, right? But you might note that there are a lot of people who were never infected by the virus who nevertheless, you might think, have at least indirectly been killed by the epidemic, right? So think back to the ventilator shortages early in the pandemic, especially in New York City. There were a lot of COVID negative patients who died waiting for a ventilator because all the ventilators were being used by COVID patients. These are people who would be alive if it wasn't for COVID. Many hospitals canceled or postponed non-emergency procedures, either because they didn't think that performing such procedures was safe because they were worried about the spread of COVID in those non-emergency wards, or maybe the personnel that performed those procedures were needed in COVID wards, they were short on PPE. Whatever the reason, there were certainly some patients who have died because they had a cancer screening postponed or a diabetes checkup postponed. Those are other people who would be alive if it weren't for COVID. We've also, unfortunately, seen significant increases in domestic violence since the pandemic started, presumably due to factors like social isolation, unemployment, and so forth, right? So all of these are examples of deaths that wouldn't have happened if it weren't for COVID. And so doesn't it seem reasonable to say that these deaths were caused by the epidemic, were caused by COVID? So what's going on here? We have one count offered by the CDC of how many people have died from COVID. Then we have a second group saying that this count is far too high. The true number is much lower. And then another group arguing that no, it's the reverse. The true count is actually a lot higher than what the CDC says. So the question is, who is right? How many people have actually been killed by COVID? Now, I think at first glance, this feels like, well, this has got to be an empirical disagreement. How many people were killed by a virus? That's an empirical question. And indeed, when journalists and other people commenting on this want to sort issues like this out, when they want to fact check these claims that the true number of deaths is higher or lower, it's scientists that they turn to, epidemiologists, public health officials, to ask them who's right in this situation, right? But in fact, the disagreement here is not primarily an empirical one. Now, that's not to say that there are no empirical questions. There are absolutely cases where a flu death gets misclassified as a COVID death or vice versa, and sorting those cases out is an empirical matter. But the number of cases like that is relatively small. The real source of the disagreement here, the big disagreement between those who think that the CDC count is a significant overestimate and those who think that it's a significant underestimate, is conceptual. The people on each side of this issue have different ideas of what it means for a death to be COVID caused. And in cases of conceptual disagreement, it is not scientists that we need to turn to, it is philosophers that we can turn to for help. So let me try to help explain to you what is going on, and then hopefully we can try to answer this question, who is actually right? How many people have actually died due to COVID? So here, I think, is a helpful way. Whoops, why is my slide not advancing? There we go. Here, I think, is a helpful way of understanding what's happening. So take all of the deaths that the US saw in 2020. There are going to be some deaths that all of us can agree are definitely COVID deaths. For example, an otherwise healthy 40-year-old contracts COVID and dies. That is a COVID death, if anything is a COVID death. There are also going to be plenty of deaths that are just obviously not COVID deaths. Imagine we're talking about a COVID negative longtime smoker who dies from lung cancer. That's just not a COVID death, pretty clearly. Okay, the problem is that there's then going to be a really large number of deaths, probably on the order of a few 100,000, where things are not entirely clear. And so here are some examples, and there's a few more in the paper if you're interested. So remember our COPD patient who, let's imagine, was maybe a month away from death anyway, but then contracted COVID and died more quickly. Should we call that a COVID death? Should we call that a COPD death? Should we say something else, like try to say it's half and half? What should we say about that case, right? Or the COVID negative patient who died waiting for a ventilator. Is that a COVID death? Is that a death due to her underlying condition? Or is that a death due to poor hospital planning, right? What about the patients who have their cancer treatments postponed? What about the victims of domestic violence? Individuals who die by suicide due to social isolation? The heart attack victims, and there were a bunch of them in New York City early on, who were afraid of contracting COVID and so waited too long to call an ambulance and died as a result of that, right? In each of these cases, each of these scenarios, I think you could make a pretty good sounding argument to either say that this is a COVID death or to say it's not really a COVID death, it's some other kind of death, right? And so what is in fact happening? What explains the disagreement that you see between people who are arguing that this number of COVID deaths is smaller than the CDC versus the people who say that it's larger than the CDC? Is that we have the people who are arguing for a low death toll are adopting very, very restrictive definitions of COVID-caused deaths. They're pretty much only counting the deaths that fall in the definitely COVID deaths category. On the other hand, the people who are arguing for a very high death toll are adopting a much more expansive definition of COVID-caused deaths. And they're counting pretty much everything in that hazy middle ground as a COVID-caused death. Okay? So that's what's going on. That's what explains this disagreement. But explaining or diagnosing the disagreement doesn't actually tell us who is right. It doesn't tell us what we should think about those deaths that are in the middle. Are they COVID deaths or are they not COVID deaths? So to begin stepping towards answering that question, let me ask you to think about an entirely different situation that has nothing to do with COVID that's going to show us something about causation. So I want you to imagine that we have a man who's unemployed and is very frustrated about his continued inability to find a job or to get unemployment benefits. As a result, he drinks too much and late at night gets in his car, misses a turn on a poorly lit road and crashes the car. So the question is, what was the cause of the car crash? Well, police officer who arrives on the scene is probably immediately going to point to the man's drunkenness as the cause of the crash, alcohol consumption as the cause of the crash. But not everyone who looks at the situation is going to cite the same cause. You could very easily imagine the man's social worker or therapist saying that the true cause of this crash was unemployment or depression, something like that. And we can imagine a highway planner, maybe a year in the future, looking back at years of crash data, who sees that people continually crash on this corner late at night, saying that poor lighting was really the cause of the crash. Okay, so we have three different people who are each picking out different causes of this crash. Who is right? Was the crash caused by alcohol? Was it caused by unemployment? Or was it caused by poor lighting? Well, it seems pretty clear to me that the answer is they all might be right. It might be that each one of those factors contributed to the crash, and maybe subtracting any one of the factors would have prevented the crash. So what we have here is a case where all three of these factors, and probably a host of other ones, were in a sense causes of the crash. Nevertheless, it is not surprising that each of the characters in our story focuses on the cause that they do. In fact, there'd be something deeply odd about a situation where the police officer showed up and said, this crash is due to unemployment. The social worker chimed in and said, I really think it was the poor lighting. And the highway planner said alcohol was the true cause here, right? That would be a truly bizarre situation to see. So what is going on? Well, Most events in the world are tied up in a really complex causal web that involves countless factors. But we as human beings often have a desire or a need or a reason to want to assign those very complicated events to a single cause or to a small number of causes. Think about how often you do things like this in your daily life. You say things like, I was late for the meeting because my car wouldn't start. Or she became such a great musician because of all the hours she put in practicing. Or he won the election because his message resonated with the public. The food didn't taste good because it was oversalted, right? In all of these cases, we're taking events that are really due to a complicated interaction of a whole bunch of causes, and we're citing a single thing or a couple things as the cause of these events, right? And when we do that, when we pick a particular cause, the cause that we pick out is going to be heavily dependent on our interests or goals or values. So in the car crash case, the police officer is someone whose job involves identifying violations of the law. So it makes sense that she is going to focus on the man's drunk driving because that is the aspect of the situation that involves a violation of the law. The highway planner is someone who's responsible for building and maintaining physical infrastructure. So she should focus on the poor lighting because that's the infrastructure element of this situation, and so forth, right? So even though there are multiple causes of this crash, it makes perfect sense that each person should focus on the particular causes that are most relevant to their interests or values or goals. Okay? So let's see what that observation, which by the way, the philosopher John Stuart Mill made almost 200 years ago, and let's see what that can tell us about the COVID death count. Okay. So just like we have a lot of good reasons for wanting to know what causes car crashes, we as a society and as individuals have a lot of good reasons for wanting to know what is killing our citizens. Keeping track of that information is going to help us to monitor health trends over time. It's going to help us to identify priority areas for research, investments. It's going to help us to assess the performance of different health initiatives. There's a whole bunch of reasons that this information is really important to us. The problem, though, is that which cause we should assign to an event, like a death, is going to be dependent on those goals, interests, and values. But there are so many different reasons that we're interested in causes of death. So take that COPD patient who contracts COVID and dies. What should we say about it? Well, for some purposes, it makes sense to assign her death to COVID. But for other purposes, it makes more sense to think of her death as a COPD death. Or take the case of the patient who dies waiting for a ventilator. For some purposes, it indeed makes sense to think of her death as COVID caused. But for other purposes, it makes more sense to think of her as the victim of poor hospital planning or her underlying condition. Okay. So what happens when we look at all of those middle cases where it was unclear what we should say about them? And if we ask whether they were really COVID deaths, the answer is, well, for some purposes, they were COVID deaths, but for other purposes, they weren't COVID deaths. More generally, when we ask whether the official CDC count is an overcount or an undercount, the answer is, perhaps disappointingly, well, for some purposes, it's an undercount, but for other purposes, it's an overcount. And maybe for some purposes, it's just right. I don't know about that, right? So what follows from this is that there is no such thing as the true unique COVID death count. Which deaths we treat as COVID deaths, as opposed to COPD deaths or domestic violence deaths, is going to vary based on what we're interested in, or based on why we asked that question in the first place, why we were interested in knowing how many COVID deaths there were. So the first thing I want to note about this is that this is a point that public discussions of these statistics haven't really understood. So here are some examples of fact checks from important organizations like Scientific America and PolitiFact, and I think that bottom one is New York Times, but it could be Washington Post. I don't remember where I got it. These all say that it's false to say that the official count is inflated, and they describe people who hold such views as conspiracy theorists, right? But what all of these fact checks don't notice is that there are absolutely reasonable ways of thinking about causes of death that would result in a count far lower than the CDC's. So the fact checks here are wrong. Now, I don't want to leave that X up too long, so I'm going to change it to a star. And here's the reason I do want to change it to a star and not quite say that they're completely wrong. It is in fact true that a lot of the people that these articles were talking about who argued for lower numbers of death did make some claims that were just false. So they claimed, for example, that the CDC had completely changed the way it dealt with mortality in response to COVID. That's not true. This has been the CDC system for decades. Or they claimed that physicians were falsifying medical records. That's also not true. So there were aspects of these claims that are false, but the core claim, the claim that there haven't been as many COVID deaths as the CDC says, depending on your perspective, that might be an entirely reasonable thing to say. Okay, but now let's go back to this idea. I seem to have kind of talked us into what strikes me as a very concerning and disappointing place, right? I've suggested that it can be totally reasonable to say that the CDC count is inflated, but it can also be totally reasonable to say that the CDC count understates the true number of COVID deaths, right? But if that's true, doesn't that make the whole statistic meaningless? Doesn't it mean that people who want to see a lower number, maybe people who want to defend the US's handling of the pandemic, could just say a lower number and we can't say that they're wrong? But then people who want to see a higher number, maybe because they want to say the US did a bad job, well, they can just say a higher number and we can't say that they're wrong either. And if nobody's right and nobody's wrong here, doesn't that mean that we can't use this statistic anymore to do things like compare the US death toll to the death toll in other countries, or to compare how well California did versus how well Oregon did, for example? Well, fortunately, none of those things are true. All of those things that I just said are wrong. And we can see why by thinking back to the car crash, right? So in the car crash, it could be totally reasonable to cite alcohol or unemployment or poor lighting as the cause of that crash. But the characters in that story didn't have that same freedom to pick out any cause that they wanted to. Given the police officer's job, she should think of the crash as a drunk driving crash rather than an unemployment crash or a crash due to poor lighting. And the highway planner should focus on the poor lighting as opposed to those other factors. So similarly, although there is no single correct way to decide what we should say about all those deaths in the middle that it was unclear, whether they should be COVID deaths or COPD deaths or whatever, that unclarity often disappears once we adopt a particular perspective or once we have a particular purpose in mind. Given a particular purpose, there are correct and incorrect ways to count COVID deaths. So let me show you how that works. So here's that same slide from earlier. And so let's first imagine that you're an infectious disease specialist and you're modeling the spread of the coronavirus. Well, you're of course going to count the 40-year-old who contracts COVID and dies, and you're going to count the COPD patient, and you're going to count the 80-year-old patient, right? The reason you're going to count those people is they're infected by the virus and you're interested in the spread of the virus. The fact that the COPD patient also had another underlying health condition is not relevant to your interests. You're not, though, going to count the patient who has a cancer screening postponed. Even though there's a sense in which COVID caused her death, the virus isn't present there, and what you're interested in is the virus. So as an infectious disease modeler, that's the path you're going to take. It's actually quite similar to what the CDC count would show you. But now imagine that instead of an infectious disease modeler, you're a hospital administrator in charge of emergency preparedness. Now you definitely are going to want to count the COVID negative patient who dies waiting for a ventilator as a COVID death. You're definitely going to want to count the patient who dies due to a missed cancer screening as a COVID death. And the reason you're going to count those is that those are exactly the sorts of deaths that an emergency preparedness program should be aiming to prevent. Finally, imagine now that you're an economist who's looking at the overall cost of the epidemic, maybe to offer some advice to the government about how much money it should spend to prepare for future epidemics or to avert future epidemics. Well, you're going to want to take a much more expansive view. You're going to want to consider things like deaths tied to social isolation. But you're probably not going to count the COPD patient. Why not? Well, that patient was going to die pretty soon anyway. And so when we think in large economic terms, whether that patient died now or a month later isn't as big a deal as all of these other factors. Okay? So I could go on to consider how things would look from other points of view, but I hope the idea is clear, right? The main idea is that, sure, there's no such thing as a single COVID death count, But once we adopt a particular perspective or have a particular goal in mind, it will often be clear which deaths we should count as COVID deaths. Okay. So let me take a brief step back to make a couple more general points. Right? So to this point, I've been focusing just on one particular statistic, the COVID mortality statistics. I think it's a really nice example to talk about, especially now, because it's one that most of us have been paying a lot of attention to. And I do think there have been a lot of people who have misunderstood the debate about COVID mortality statistics. But there really isn't anything special about that statistic other than maybe its timeliness. I could have given pretty much exactly this same talk about different ways of measuring economic inflation, different ways of assessing sea level changes associated with climate change, different ways of assessing the cost effectiveness of donating to an anti-malaria charity, different ways of measuring the benefits of a new cancer drug. Right? In all of these cases, there are many different ways of putting those statistics together, which can all be reasonable, but which can alternatively make the situation look a lot better or a lot worse. Now, in saying this, I am, of course, just telling you something that you all already know, even if you didn't think of it precisely in those terms. We've all heard this phrase. We all know that statistics can be presented in ways that make one side or the other look more appealing. And the result of this situation, at least in public and political contexts, I think is really bad, right? When we have these situations where we have dueling experts who each present statistics that make their side look good, well, that's not a good recipe for a productive public discussion or I don't know, healthy political dialogue. So what can we do about the fact that we have these statistics that can be presented in multiple different ways that make alternatively each side look good on some issue? Well, what I think most people want in this situation is they want to have an expert come in and tell them which statistics are the accurate ones and which statistics are the inaccurate ones. They want someone to distinguish truth from lies, right? That's why when there are these disputes about the COVID death count, journalists go to scientists. But as we've seen, this often isn't possible. In a lot of cases, like with the COVID death count, there may be multiple different ways of calculating or measuring things. And independently, each of those can be a totally reasonable way of doing so. So we can't just simply classify the statistics into this is the accurate one and all these other ones are inaccurate. What we can do, though, as we just saw, is say that certain ways of measuring things are more or less appropriate for certain purposes or given certain uses, right? And so in the case of the COVID death count, yeah, there are absolutely reasonable ways of counting COVID deaths that are going to end up with a number far lower than what the CDC arrived at. So when people say this, we can't necessarily say that they're making a mistake. They might be saying something true, or maybe there's some problems behind it, but there's not necessarily anything wrong with that claim. But it is also true that those ways of thinking about causation, the ways that would lead you to get a very small number of COVID deaths, don't make any sense to use for the purposes of assessing the US's pandemic response. So what we can do is we can object if someone says that because there have been fewer COVID-caused deaths than the CDC reports, we shouldn't be so critical of the US's pandemic response. That claim is not okay. And it's not because the statistic itself is wrong. It's because that statistic is not well suited to that goal, that purpose. The reason for that is because a lot of those deaths in the middle category, things like the patient who died waiting for a ventilator, are absolutely deaths that are relevant to assessing how well our country has handled the pandemic. Okay. So here's where that leaves us. When we're having public discussions about things like the COVID death count or sea level change or inflation rates, we can't do the easy thing and just say there's one right way to do it and all the other ways are wrong. Instead, what we have to do is we have to have someone who can determine which statistics or which versions of a statistic are more or less appropriate for particular goals or purposes. And that, unfortunately, is a much more complicated, nuanced assessment to make than just, is this right or is this wrong? So whose job is it to make that assessment? Well, Usually, this task is left to the users or consumers of scientific information. Scientists go off and create whatever statistics they want to create. Then advocates on each side of an issue present whatever statistics they think makes their side look good. And then it's the user, whether that's the public, policymakers, investors, institutional administrators, whoever, who have to then decide which statistics they should rely on, which statistics are the ones that are best suited given the purposes that they have or the decisions that they have to make. I think the reason that we have this division of labor is that in an ideal world, it makes a lot of sense. The decision maker is the person who is usually best positioned to know what her goals or purposes are, so she should be the one who can best choose which statistic is relevant given her goals. In practice, though, this is a terrible system. And the reason it's a terrible system is that statistics like these, as we've seen a little bit here, are highly technical and complex. Most decision makers do not understand them well. And even if they do understand how some particular statistic was calculated, maybe they know how the CDC calculates its numbers, they often don't know what alternative approaches could have been taken instead. And so as a result, in many cases, we have decision makers who are presented with statistics, but who don't have a clear way of knowing which statistics are the ones that are most suited to their goals or purposes. So what is the solution to this problem? Well, the first thing that most people say is, well, we need to better educate people. We need to better educate policymakers and the public so that they will be able to choose the right statistics, to choose the statistics that are most relevant to their goals. This, I think, though, is not a very good solution to this problem. I love the idea of trying to promote greater scientific understanding, numeracy, these are great, but so much of this out there is so technical, and the gap between what people do know and what they would need to know to be able to make these determinations is so large that we're just not going to solve this problem in the near term by putting the onus on the users of scientific information. So I think what we need to do instead is to put a large part of this burden on the producers of this information, and especially scientists, right? The scientists who are producing these statistics, I think, need to think carefully about the uses to which their statistics either could be put or likely will be put. And then they need to figure out how they can tailor their statistics to those uses. Scientists doing research on COVID mortality need to ask themselves, who are using my data? And what definition of COVID-caused death is most relevant to the kind of uses that these people are going to have in mind? So they need to think carefully, tailor their statistics, and then, of course, they need to follow that up by explaining as clearly as they can how their statistics should be used and how their statistics shouldn't be used. I've read a ton of papers about COVID-caused mortality, and virtually none of them do that. I don't think I found a single paper that discusses more than 2 possible ways of thinking about causation when I gave you 3 just a few slides ago. Okay. Now, if we're going to ask scientists to do this, they're going to need to explicitly reflect on policy issues, and that's going to wrap them up in accompanying really hard questions connected to social problems, ethical issues, things like that. Doing that well is hard. I'm a professor of ethics and political philosophy. I think these are really, really hard things to think through carefully. And so if we're going to ask scientists to do this, we need to give them training. And that means we need to integrate more emphasis on social issues, political issues, ethical issues into the science curriculum. Okay. I'm going to leave that there. That would be a whole nother talk. But that, I think, is the right way to think about how we could make progress on these issues. I see I'm almost at 40 minutes, so let me end with just a few quick takeaways to kind of wrap up what I at least hope I have convinced you of or explained to you. First point, although lots of people have argued about whether the CDC count over or undercounts COVID deaths, in fact, everyone may be right here. Because deaths are part of a complex causal web, there are a number of different ways of deciding which deaths to count as COVID caused, and each of these approaches can be a reasonable one. Second point, what that means is that there's therefore no such thing as the true COVID death count. However, that doesn't mean people can just say whatever they want. Certain ways of counting COVID deaths are suitable or unsuitable for particular purposes or goals. So fourth point, how can people tell whether a particular statistic or a particular version of a statistic, like the COVID death count, is a good one for their particular purposes or goals? Well, that task is usually left up to users or consumers of scientific data, but I suggested that given how complex and technical a lot of this stuff is, the burden should in large part be shifted to scientists. But if scientists are going to do that well, they're going to have to receive much more extensive training in matters like ethics, values, politics, social issues than most of them currently receive. So thanks very much for listening to the talk, and I look forward to hearing your thoughts or your questions or your ideas. And there's that URL again for the article. Thanks.
Thank you so much, Professor Schroeder. That was very interesting. I encourage anyone to add your questions into the chat or be brave and raise your hand. You can ask your question directly. Linda added in the chat, what an amazing use of political, philosophical, ethical perspective.
Thank you.
Any questions? All right, Art, would you like to unmute and ask your question directly?
Sure, I'd be glad to do that. Good afternoon. So, Andrew, expand on your comments regarding when it comes to the debate over the zero-sum game called funding, whether it's research purposes or more money to do X, because somebody's going to read that and say, my area Y is going to perhaps not get as much as I would like. Your comments regarding how do we consume to fund things better?
So I've actually spent a lot of time talking to epidemiologists who are very worried about this, not so much because they themselves are looking for funding. I mean, they're always looking for funding, but because they know their statistics are used for these purposes. And so what happens right now is interest groups, by which I mean people who are trying to get funding for cancer research versus diabetes research versus whatever, will often craft statistics to make their problem look as serious as possible. So they will go back through COVID deaths and identify all the COVID/cancer deaths, and they will reclassify them as cancer deaths so that they can report that their research shows that there were X many people who died from cancer. So this is a very serious problem and you need to give me money so that I can solve that problem. And it's also a horrible system because it is this dueling statistic situation. I think one of the epidemiologists I was working with said that the WHO was presented with a bunch of funding requests. And if you added up the number of deaths that all of these groups claimed, they had killed like everyone in the world 4 times over because they were all trying to count the same death as attributed to their cause. So the best idea I have to respond to this situation is there is no single correct way to do it. So what we need to do is we need to establish a set of rules that's fair ex ante, and then everybody has to agree to kind of play by those rules. So we kind of set up a standardized system without hopefully knowing in advance who is going to benefit from this. And then we recognize that in the end, some people will end up benefiting and some people won't, but that's the virtue of a standardized system. And so I think taking something like the official CDC count, I would tweak it in a few ways, but taking something like that as a baseline is not really a bad idea, even though it's far from perfect, because it at least gives everybody the same playing field to use.
Thank you. We received a question in the chat that dovetails into that from John and says, the CDC reports COVID-only deaths, which are much lower than those with comorbidities.
Mm-hmm.
How would you suggest that we reconcile those numbers?
Well, so I think, and I would need to go back and check because I haven't checked on this. I think the COVID-only deaths, yes, are going to be those without comorbidities, and that's going to be a much lower number of people. Now, that still is going to disguise or it's going to hide a bunch of really important distinctions, because those are going to run together cases like the COPD patient that I mentioned, where the comorbidity is a really, really serious one that was going to kill the patient anyway if they hadn't got COVID, from cases where there was a comorbidity, but it was not likely to kill the patient anytime soon. So imagine someone who has well-controlled HIV, well-controlled HIV, that would be listed as a comorbidity, but that's a patient who could have gone on and lived for 30 more years if they hadn't contracted COVID. So I think that just the distinction between comorbidities and no comorbidities, or COVID-only deaths or COVID plus something else, doesn't really give us especially useful information. So this is one of those times when I think it would be valuable for researchers to go through and look at some of those things and start to classify them based on comorbidities, to distinguish the case where we have comorbidities that are really serious and could reasonably be described as more important than COVID, like the COPD case, from cases where the comorbidities don't really seem like they're more significant. So that's not a full answer, but I think it just shows that these simple distinctions that a lot of people want to make can sometimes prevent us from doing the really hard work that we would need to do in order to get useful information out of that.
And then can I just ask a follow-up on that to my question then? So if that's the case, and as you said, we really should be breaking this out in more detail to understand how to handle it. How do things like the prevention, like mask wearing, and don't you kind of need that data in order to suggest a solution and a prevention option?
Well, so look, yes. And so I think with mask wearing in particular, a lot of people have focused on its impact on case counts, not its impact on mortality counts.
Yes.
I mean, people have looked at both. And so case counts are a whole different issue, and there are absolutely problems with that statistic as well, but I didn't talk about that today. So yes, what we ideally would want to do if we're using COVID mortality data as a feeder into other studies, like studies of the effectiveness of mask wearing, is we need to pick tailored COVID mortality data, not just take the CDC stuff off the shelf, because off the shelf data, for the reasons I'm pointing out, may not be well suited to that purpose. So I agree with you.
Thank you. Another question in the chat asks if you could comment on the excess death statistic.
Yeah. So the excess death statistic is very close to what I mentioned as how the economist would handle things on that screen where I had all the different ways of thinking about things. So the excess death statistic is, in addition to the CDC method, which is the death certificate method, is the second kind of way of counting COVID deaths that's in general circulation. And it works like this. And there's more detail on this in the article if people are interested. Researchers look at how many people died, let's say, in the US in June 2020. They compare that to the average number of deaths in June between 2015 and 2019. And if we see a much larger number of deaths in June, and we say, well, look, COVID was the only real significant difference between 2020 and those other years, we say that those extra deaths, those excess deaths, the larger number than the average from the previous years, must in some way be linked to COVID. Now, so far, this measurement doesn't tell us whether these are people who had the virus and died, or whether these are the people who died COVID negative waiting for a ventilator in the hospital. And so a lot of people have argued that this assesses the true coronavirus toll. And for the reasons in the article, I don't think that that's right. I think it's absolutely a reasonable way of assessing how many people have died of COVID. It's essentially saying how many more people died last year than died on average in the previous number of years. And so for some purposes, that's a great way of counting COVID deaths. But for others, it's not. And I think one example that can bring this out well, talk about this a little bit in the paper, is the case of a domestic violence death. Right? We have seen increases in domestic violence. And so if we take an excess mortality approach, those extra deaths are going to be chalked up as COVID deaths. But I think that for a lot of purposes, for legal purposes, for ethical purposes, we don't want to kind of let people off the hook by saying, oh, well, COVID was the cause of this death. No, this person's partner was the cause of her death in that situation. And so for a lot of purposes, it just seems wrong to call that a COVID death. And so this just shows, again, the context sensitivity of these judgments. But yes, excess mortality statistics, if you're interested, there's more in the article. That is the source of that New York Times article saying that the true count was about 25% higher than the CDC.
Thank you. We have another question in the chat coming from Catherine that says, how would you respond to people who claim that deaths such as drug overdoses and suicides are due to over-restrictive government responses to COVID rather than the virus itself?
So I think this is absolutely one of those questions where the reason that you ask the question is going to dictate what you should say about it. So for some purposes, I think it's entirely reasonable to say, look, if all these extra people died due to COVID, and I'm a government official deciding whether it's worth spending money to prevent a pandemic in the future, well, if I can prevent their deaths as a government official, I'm going to do what I can to prevent their deaths. And so it's so totally reasonable for me to include those in the count. But yes, for a lot of these other purposes, we might not want to count those. We might want to instead consider those deaths due to government overreaction in certain cases, things like that, because there have been a lot of other consequences of government actions, and we'd have to engage in some kind of a political or ethical discussion to decide whether those actions were warranted. But our judgments about whether those actions were warranted are going to influence what we want to say about those deaths, right? If you're the kind of person who thinks the government was fully justified in shutting everything down, then these deaths due to social isolation, you might be more inclined to say that they're really due to COVID, because after all, the government only did what was reasonable. On the other hand, if you think the government was not justified in imposing these restrictions, and those restrictions led to people die, then you'd be much more inclined to say that it wasn't really COVID, it was the government's overreaction. And so that again shows how complex all of this stuff is.
Thank you. Another question in the chat from Linda asks, in your opinion, why did the media not pick up on how the stats were originally manipulated?
So I think the problem is that, a lot of the media did pick up on what was going on. Like they were able to, if you read those fact checks, they were able to tell that the people on the undercount side were trying to subtract those deaths with comorbidities. They were trying to subtract out the COPD/COVID deaths, right? And they could tell, on the other hand, that the excess deaths people were trying to throw in all of those deaths. So I think they could tell what was going on. And if you read the articles, the more insightful commentators do mention those arguments. What they weren't then, what they didn't, I shouldn't say weren't, I don't know what they were thinking. What they didn't do then is point out the fact that none of these perspectives is necessarily the right one, or necessarily in some abstract sense, the right way to count COVID deaths. And my sense is that in a lot of cases, the reason that journalists didn't do that is that they don't want to themselves be part of the story. And so they want to just go ask somebody who can give them an answer. And so they go to the scientists, and the scientists, in many cases, I think were very worried about the lack of seriousness with which people were taking COVID in certain parts of the country. And so they didn't want to engage in a nuanced discussion about, well, yeah, there are certain perspectives from which we could say the death count is lower than the CDC says. They wanted to reinforce how serious this was. And so they felt that the right way to do this, which again would be the topic for another talk, was to just say, hey, look, we have the CDC count. The CDC is just using its standard procedures. So you're wrong if you say that the death count was, that much lower.
Thank you. Another question asks, can excess US deaths for 2020 be used as an approximation for a total of COVID deaths?
Yeah, so this goes back to what I was saying earlier. Can it be used? Absolutely. I think there are absolutely all sorts of purposes for which it is entirely reasonable to say that how many deaths was COVID responsible? A really good guess will be to just compare how many people died in 2019 versus how many people died in 2020. And that's going to give us a really good estimate. But for other purposes, I don't think that's a good way of doing it. And I hate to be this person who's like, well, for some purposes, yes, for other purposes, no. I always tell I see a few students from my intro classes here, I always yell at them and I tell them they have to pick answers to questions. They can't do that. Well, kind of yes, kind of no. But here, the truth is, it's a kind of yes, kind of no situation. And so, yes, you can, but that doesn't mean you can't also say that from a different perspective, the true number of COVID deaths was substantially lower.
Thank you. And the last question I have, how do the total US deaths for 2020 compare to 2019?
So I don't know that exactly. What I can do is I can go back and look at that chart. So in let's see, we have about 350,000, going back to the chart I said about top causes of death in 2020, there are about 350,000 deaths that were attributed to COVID, according to the CDC in 2020. Most of the excess mortality statistics that I've seen have pegged it at about 20, 30, 40% higher than actual COVID deaths. So I'm going to guess, and you can check and see if I'm right about this, that we're somewhere on the order of 450,000 more deaths. See if I'm right about that. I don't know. Someone can probably Google it right now and tell me if my back of the envelope thing was close or not. But that's just a guess. You should look it up.
Thank you so much. Well, in an effort to make sure we all stay on time, I want to say thank you so much for this presentation and giving us your time. Thank you everyone for being here. Feel free to unmute and say goodbye and thank you. And we will see you in the coming weeks with some more programming.
Thanks,
Bye,
everybody.
everyone.